Alright guys, welcome to Road to 250. Today we're just going to have some review questions, so right into it. A 66-year-old man is brought to the ED by his wife because he has not been himself for the past 2 hours. He has a history of hypertension, diabetes, and has been smoking for 30 years. And he has had 3 hospitalizations for cerebral infarcts. He appears to be disoriented to person, place, and time. Physical exam shows downward drooping of his right lip and inability to close the right eye. Which of the following is the most likely complaint based on the location of the lesion? So, hypertension, all that is there, but downward drooping of the right lip and inability to close the right eye are pretty key findings. So first of all, what does this patient have?
Does he have...
Clearly he had a stroke, right? So now you gotta think which cranial nerve essentially does the drooping of the right lip and inability to close the right eye.
Trigeminal.
Okay, so yesterday we talked about trigeminal being sensory and motor, and the only motor function it has is jaw mastication. So muscles of mastication are the only motor functions that trigeminal has.
7.
Correct. So facial. Now, facial nerve, obviously, with like a palsy, you have to think of upper motor neuron and lower motor neuron lesions. So would this be an upper motor neuron or lower motor neuron? So obviously, if you think it's not trigeminal, you can rule out inability to open the jaw because that's cranial nerve 5.
And you can rule out C because that's like Horner syndrome.
Correct. So is ptosis.
And E.
Ptosis, yeah. And then numbness of the face, obviously, that can vary. I'm pretty sure that one can also go with cranial 5. So that leaves you with this one. Hypersensitivity to sound is the correct answer. So he suffered a stroke, which led to a facial nerve palsy. So these symptoms of the palsy depends on the location of the lesion. So if it's an upper motor neuron lesion, it will manifest as a contralateral paralysis of the lower muscles of facial expression. So the facial nerve is innervates the stapedius muscle, which stabilizes the base, so it dampens the vibration in response to sound. So if it's an upper motor lesion, again, the forehead is usually not affected because it's bilateral innervation. So if a patient suffering from lower motor, then it will manifest as ipsilateral paralysis of the upper and lower muscles. So this patient is suffering from a lower motor neuron and will have hypersensitivity to sound. But you can also use the rule of elimination. So any questions on that one? Okay. So the next one is a 62-year-old woman presents with sudden onset of double vision for 3 weeks duration. She denies any head trauma. She works as an editor and states she has trouble reading manuscripts unless she holds them far away from her face. Patient has a long-standing history of hypertension and diabetes, but she does not see her physician regularly and has trouble keeping up with her medications. On examination, her right eyelid is drooping and her diplopia improves slightly with a right and downward gaze. The pupils are equal in size bilaterally, which this patient's extraocular muscles are still functional.
E?
You said E?
Wait, no.
All right, so before you give me an answer, think of this. Keep that in mind. Eyelid is drooping, and the diplopia is slightly with the route and downward gaze. So first of all, which cranial nerve is affected?
3.
Correct. So that means which cranial nerves are still functional?
6 and 4.
Correct. So which one do these muscles get innervated? Which muscles are innervated by those 2 cranial nerves?
The superior oblique and lateral rectus?
Correct.
So that's... Oh, there it is. Okay.
Yeah, lateral rectus and superior oblique. LR6SO4 as the mnemonic. Does anybody need an explanation on that one?
Nope.
Like I said yesterday with diabetes, just make sure you can get the constriction still. So if that question was to change and said the patient's eyes constricting normally, don't get thrown off by that. Because diabetes only doesn't affect the constriction because it doesn't affect the parasympathetic fibers. So just keep that in mind. Any questions? Cool.
All right. So a 23-year-old man is brought to the emergency department after collapsing during basketball practice. On admission, he's lethargic and appears confused. His coach reports that he was in a hot gym and he was drinking a lot of water during practice. An increase in which of the following most likely caused his symptoms?
D? Maybe. No. Yes. No.
I say C.
So yeah, the answer is actually C. Because he was, there's like a shift of fluids. Let me just...
So if he was sweating, he's losing salt, but
Right.
if he's drinking water, he's only getting water back.
Right, so it's
Right.
not making up for that loss of sodium.
Yep, exactly.
And the brain swells. That's why he collapsed.
So there's more salt within the cell, so the water is going to go into it.
Right, water's all.
Gotcha.
Good?
All right, the diagram below illustrates the concentration of a substance in two chambers. If the concentration of the substance in chamber A doubles, the diffusion of the substance will change from 10 milligrams per liter to which of the following?
This is asking of substance in chamber B?
Yeah.
Okay.
So chamber A becomes 40.
Mm-hmm.
Oh man, if there's 10, this thing's gonna flow to the right.
Because I'm
So
thinking
we're looking at like rate of diffusion. So
right, but my question is, if it becomes 40, and if you're trying to balance, right, like the diffusion has to be equal on both sides. So does that mean both sides have to be 20 each?
No, because so like right now it's 20 in A and 10 in B.
And it's equal.
So obviously, and like that's the number is indicating like solutes.
Okay.
And what's diffusing.
Oh, so this is balanced right now.
Yeah.
Okay, then it has to be 30. Because if A doubles, then it becomes 40, right? So if you're still keeping the 10 difference to be balanced, then this chamber B would have to be 30.
Yep.
A 3-year-old boy is brought to the office with 5 days of productive cough and fever. Exam shows a tachypnic, ill-appearing child with ralls over the right lower lung. Chest x-ray reveals right lower lobe pneumonia. The boy is admitted to the hospital for IV antibiotics. Review of his medical history shows 4 prior pneumonias, and his weight is at the 3rd percentile. Further testing demonstrates high sweat chloride content, and genetic sequencing shows a mutation in a transmembrane protein. Which of the following best describes the dysfunctional transmembrane protein causing this patient's disease?
A.
A.
A is correct. And if you hit one more time, explanations for the other ones. So when we're talking about cyclic nucleotide gated, we're talking about membrane proteins that are activated by cyclic nucleotides, for example, CAMP. And these are important for photoreceptor and olfactory receptor neurons. When we're talking about mechanically gated, it's also known as stretch activated channels. So that's that there. And temperature gated, we're talking about channels that open in response to heat. and voltage gated, of course, open and close in response to changes in electrical membrane potential. So what does this kid have?
Oh, cystic fibrosis.
Right. And the CFTR gene for the
Chromosome.
chloride channel is ATP gated. So, woo,
Mhm.
good going, y'all.
So just a follow up. If it's less than 5, it's Staph aureus, the infecting agent, correct? And greater than 5 is Pseudomonas?
I'm not sure about that.
That's fine. Okay, all right. Just checking.
They're saying like number of days?
No,
No,
like
for
5
the
years
age.
old. If they're less than 5 years old, I think it's Staph aureus. I'll double check on that. And if they're greater than 5, it's Pseudomonas. But I think I've read that somewhere, so I just wanted to just clarify it. But I'll look it up for you guys.
Oh, yeah. That's interesting. I've never heard that. So if you do find that, I'd like to know more.
All right, so next one.
A pharmaceutical researcher is studying effects of a new drug, not drugs, being developed for treatment of asthma that works by reversing irritant-induced bronchoconstriction. Laboratory guinea pigs are divided into 2 groups, a post-vagotomy group and normal study group. And post-vagotomy just means they had their vagus nerve transected out. Then both groups are exposed to the irritant without receiving the study medications, and changes in bronchial diameter are recorded, and that's figure 1. Subsequently, both groups are exposed to the irritants but are also given the study drug, and that's figure 2. The study drug is most likely similar to which of the following medications? So the blue line is the post-vagotomy guinea pigs, and the black line are the normal ones. And then figure 1 is without the medication, and figure 2 is with.
Okay.
So you see a change happening in the normal study group. After they're given the drug, they have less bronchoconstriction. But there's no change in the post-vagotomy.
Vagotomy. So, right. Now, what works through the vagus? Why?
Because you're not. I mean, wouldn't you bronchodilate with an albuterol?
Yeah,
that's what's happening.
You have less constriction, so it's
less constriction. The diameter of the bronchial dilation is greater, allowing for more breathing. I'm thinking. Okay, so albuterol, and then ipratropium, that's like for COPD. But besides the fact, it is a muscarinic.
Correct.
And then theophylline is like nifedipine, calcium channel blocker. I don't think I'm ruling that out. Xylitol, that's talking about arachidonic acid and lipoxygenase and leukotrienes. So, okay, wait a minute. Leukotrienes. The B is the neutrophil chemotaxis, and the rest are dilators. I mean, they cause constriction, so if you inhibit. Okay. So A or F, I think, is where I'm at.
Okay.
But I think I'm gonna go with A.
Okay.
Because of the post-vagotomy and how it's unaffected. I don't know.
Yash?
No clue.
The answer is ipratropium. So what you want to think about in this question is that when there was a lack of a vagal nerve, the medication didn't make a difference. So what you want to think about is that this medication works at the level of the parasympathetic nervous system. And when we're talking about that, we want to think about when the vagus nerve is intact and it's stimulated, acetylcholine is released. And acetylcholine produces bronchoconstriction on muscarinic receptors. So ipratropium is our anticholinergic agent, which blocks this. So if you don't have vagus nerve stimulation, then ipratropium is not going to make a difference, which is what you see in the post-vagotomy guinea pigs. And albuterol is independent of parasympathetic innervation. So if they were given albuterol, both groups would have had changes. And and then all of these drugs can be used for asthma, so that's also there.
What is a flunisolide?
Flunisolide is an inhaled glucocorticoid.
Okay.
Is used for prophylaxis.
Like a punisolide.
Yeah. It's mostly a prophylactic treatment for asthma, so there's that. Any other questions, comments, concerns about this one? Alrighty. And that's all.
So if you guys look at cystic fibrosis in the biochem section, it says recurrent pulmonary infection. Yeah, it says recurrent pulmonary infection in early infancy is Staph aureus. But somewhere I had gotten the information that it was up to the age of 5, but I'm not 100%. I'll look that up.
Wait.
And then Pseudomonas is adolescence.
So you're saying younger than 5, Staph aureus, older than 5, Pseudomonas.
There's 4 main ones. Hold on, let me pull up the picture real quick.
Yeah, the bugs make sense. I just didn't know they were also differentiated by like age group and when they get most affected.
Yeah. Age specific prevalence. So age 5, if we're talking about 5 and under, Staph aureus is the highest. See Pseudomonas kind of taking over after age 18 though, because you still have staph high up until this kind of their exchange point. Cool.
Yeah, I know that there's an MBME question. You got to be careful with the age range because they do ask that question.
Yours says 5.
I know the differentiation figure was 5. Like one was less than 5 years old, the other one was like a 13-year-old kid. So
that kind of gets into this range.
Yeah, it's like in that gray zone where it's a differentiation here, but if it's like a 5-year-old kid, then it's Staph aureus. If it's like a 10 to 13-year-old.
Cool.